Well, thank you, Andy, so very much. I really, really appreciate that. And, it's always so wonderful that you actually, to hear some of this and to know that this, that this is remembered. And here's another one for you. And it's actually not my own, but it's from the Hebrew sages, which is of all my students, I learn. And so I want to throw that back at you because of all my students, including and perhaps, you, I learn and I continue to learn from all my students and from you, Andy, I just continue to learn. And so I'm so, what goes around comes around. So thank you very much for that. And also thank you for the honor of being able to present at this Future Directions conference. It was an opportunity for me to reflect on what I've been doing for more than half of my life, which is actually trying to help and understand anxiety problems in children. And so I think you'll hear from my presentation a reflection of my reflection, because you'll be hearing some historical perspective, because I have been doing this now for, as Andy said, he was an undergraduate, at FIU as an early mentee. So this has been a really interesting journey, and I'm really happy to share this with you. And I hope you'll, find it interesting and informative. My only disclosure is the royalties from the Anxiety Disorders interview schedule, which I will be speaking about briefly. And the objectives of my presentation is to summarize the knowledge and to identify knowledge gaps in clinical trials of cognitive behavior therapy of pediatric anxiety disorders. I also want to highlight my journey to enhance outcomes by augmenting and dismantling clinical trials with parents and with attention training. And throughout my presentation, I will be weaving through clinical discoveries and implications, and then I'll talk about ongoing and future work. So that's my objectives. I do want to go back though and just comment on the title, which will be clearer to you as I get into it. But I also want to mention, I will be calling the work I do and that we do clinical trials, but I do want to emphasize that this title, experimental psychotherapeutics, is what NIH refers to clinical trials these days, experimental psychotherapeutics. I actually really, really like this term, because what we do when we're doing clinical trials is carefully controlled experiments. And I hope you'll get a taste of that as my presentation continues. And here's the structure of my talk. First, I'll give some background. But as you can see, then I'll talk briefly about CBT efficacy and effectiveness. Then I'll talk about sampling limitations. Then I'm going to get into the work we've been doing with parent involvement, and then which has really been the bulk of many of these last couple of decades. And then the more recent decade is the attention retraining work that we're doing. And then I'll talk about the takeaways and ongoing and future work. So I said I'm going to give some historical perspective, and I think it's really important that I do. First of all, in terms of anxiety, they're highly prevalent. 75% have an onset before age 21 with a median age of 11. This is why we need to begin early, because it has such an early onset. And the lifetime prevalence anywhere in in the population is almost close to 30% lifetime prevalence. And these are extremely impairing, high burden to society and family. And I put on the column there the list, and it's not a perfect carved in stone, but generally this is the developmental trajectory of when we see the different anxiety disorders in terms of the earlier ages of phobias, mutism, and then you can go down to see how we get more into middle childhood and into adolescence. The disorders that have the asterisks or have asterisks next to them, because they are the ones that in the clinical trials where most of our work has been focused on. So when I talk about the anxiety disorders in the trials, generally these are the disorders that we focus on. And I also need to speak again about, like, some of you out there may not really know, because some of you I know were not born. Certainly you were not born when the DSM-3 came out, and maybe some of you were not even born when the DSM-3R came out. And so I want to just give a little history here, which is that when I began my career, which was in the early 80s, that was the first time the anxiety disorders even came into existence as a diagnostic entity, only then. And so before then in DSM-2, there was only something called over-anxious reaction. So I started my career. These new disorders came out. They were and I knew at the time, speaking of mentors, I began my career at SUNY Albany, and I do view David Barlow as as when I was a faculty member as someone I viewed as a mentor, and he had at that time a very doing really important work with adult anxiety disorders. And so he developed the anxiety disorders interview schedule so he can begin to phenotype adults with anxiety disorders, because to do the clinical trials, one needed to do this careful phenotyping. So that led early on in my career to begin this journey of developing an instrument that we can use carefully for diagnosing anxiety problems and classifying them. And we've had these different versions in the DSM, in the latest DSM-4, DSM-5 version. Anne Marie Albano has become a co-author with me on this disorders interview schedule. And I'm sharing this with you because I also, and just as an FYI, all the publications that you see here are in the Dropbox, all of them. So you'll find them there. And so the anxiety disorders interview schedule has become the gold standard, so to speak, and it's been translated. And this is an article that came out recently with an editorial by Joan Luby about how to take the interview schedule and deal with some of the tricky issues of dealing with child-parent discordance, how to deal with comorbidity, et cetera. So, and it's nice to know, though, across the field, people are now trying to become uniform in how they phenotyping children in these trials, which is, obviously quite important. We also have, besides interview schedules, dimensional measures for anxiety disorders. And in the, I was very happy when Andy asked me to write with my members of my team an update on the using evaluative criteria to review youth anxiety measures. And we have two versions, a part 1 and a part 2 version. And I just want to, this is a table from the youth measures. And I think the bottom line here is, and you can look at the articles, the bottom line is that we have several really good measures. And if you look at the criterion, norms, internal consistency, retestability, the measures are good to very good. And we should feel really positive about these measures. And I guess when a lot of people critique these measures, but if you look at the very careful review where we covered 136 trial papers and 55 parents, these measures really hold up quite well, with the SCAD being probably currently the one that has the most strongest evaluative, meeting the strongest evaluative criteria. In addition to interview scheduling and dimensional measures, it's also important to do a multi-method assessment. And we are doing a multi-method assessment in all of our work. And I don't have, and again, these are papers, but we're using some very innovative kinetic movements to tasks to get behavioral avoidance, with measuring parent-child interactions. We have behavioral measures, as you could see with that boy in the classroom, with measuring eye gaze, and again, have measured and have, and we're using these in our trials, and also just to get a sense of what anxiety disorders, what the phenomenology of anxiety is like using these different behavior targets. Similarly, we have biological neural measures that we've been collecting data on, and including getting some grants on. So with some colleagues, we've been working on FGF2, we've been doing neural correlates, the figures there with the rainbow is genetic work, brain scanning, and that necklace that looks like a Tiffany necklace is actually oxytocin. So we also have been measuring oxytocin as between children and parents, and looking at that as a possible target. So So that's what we do in terms of assessment. And again, here are some sample papers that give you more information how they can be used. Okay, but now assessment, 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 super important. And that's another phase, another thing I always say, assessment, assessment, assessment. But now that I've mentioned that we have good interview schedules, dimensional measures, we have behavior targets, we have biological targets that we're studying, let's now talk about treatment. So the very first individual CBT trial was done by Phil Kendall in 94. We published the first group cognitive behavior therapy trial in 99. We compared with a wait list. And you could see here the findings from our GCPT study, which was very similar to the individual CBT trial. But what I think is also really interesting is if you look at the latest Cochrane review, which was in 2018, so this is 20 years after the Silverman 1999, where 41 studies, 1,800 participants compared CBT with participants. And if you look, it's amazing how similar the findings are 20 years later. 60%, 59 remission rate, we found 64 and versus 15 versus 13 for us, and medium to large effects. The durability does vary across the studies, which is a theme I'll talk about that needs to be emphasized. But that's the initial CBT work. Since then, there's been many trials, and there's also been an interest in looking at predictors of CBT. And we actually published some of this work in our own trials, but we also published a paper looking at predictors with the CAM study, which I'm assuming most of you are familiar with. That's the large multi-site study. And what we found looking at the CAMS data is that severe anxiety, especially social anxiety, and especially low SES and OCD was a main effect of a predictor of poor outcome. And I'm saying this here now because when I get to the attention training work, you will understand why we are focusing on social anxiety. Social anxiety has been a thorn in the heel, I think, of CBT, and we do need to develop improved methods. And so that's actually, I already gave you the reason why we have this slide. It also was a predictor of poor outcome in the follow-up work. Okay, so I've spent most of my career doing efficacy trials, and which I'm going to get to. But I also more recently have been involved in a really exciting collaboration with researchers in Denmark. This is Pia Jepsen. She's a child psychiatrist, and we published an effectiveness trial in JAMA Psychiatry. And I want to share that with you because, everything is everything and everything is really important. And I wanted to share this with you to show how we're having strong evidence that some of this work can be disseminated. And so this was a Mind My Mind effectiveness trial. You can see up for yourself what it involves. And you can see there. And I was excited about this because I was involved in helping to consult on the anxiety module and the flow charts. And what was nice about it was that it was very flexible. We had different methods of sequencing and dosing the modules. The parents were not as involved, were not monitored carefully. They were all engaged as co-agents of change. And so this was a prototype for anxiety. It involved psychoed for this particular child, but we had different flow charts for different children. And it's too complicated actually for me to explain how this was done, but I am aware that many of you are probably not interested, not just in efficacy, but effectiveness and dissemination. So here is a paper that explains how we identify and stratify these children using a very novel stage-paced step care. So this was, so this is how these children were, how we decided to do what with which children using this very flexible modularized approach for anxiety plus other problems as well. And what we found is the management as usual versus the Mind My Mind, which is the experimental group. What we found, as you can see, is that children in the experimental group improved more according to the parent rated, and the SDQ is the strength and difficulty questionnaire. Those of us here in the States may not know this measure, but in Europe, it is the measure that is, ubiquitous in European anxiety trial, European in Europe. It's similar to our child behavior checklist, but they're using Robert Goodman's SDQ. So using that measure, we found the experimental group receiving the intervention did better than the treatment as usual. And this was true as well with the teachers. It confirmed teacher ratings, and children reported decreased anxiety, and there were no adverse effects. And we're currently doing more papers from this really, really interesting study, I think. So let me stop here and just do the clinical discovery here. So there's international consensus that that you can go to with that article on phenotyping pediatric anxiety disorders. Child and parent ratings for pediatric anxiety are generally good and excellent across a wide range of psychometrics. CBT is efficacious, about 60%, although about 60% omit. But keep in mind, CBT to do as well as it does, 12 to 14 sessions. I mean, that's really, really a good, powerful treatment. But still, we need to improve on it, and we need to especially work on on those who don't do as well, which is adolescents with social anxiety. And what I also showed you through the Denmark work is that these CBTs, including for anxiety, can be successfully disseminated in effectiveness trials. Now that's the good news so far. Let me stop now for some bad news. In 2003, Armando Pina, who I believe is involved in this weekend's conference. Armando, if you're out there, hi. But Armando was a graduate student at the time, and we published this paper, and we looked at what the samples were. We compared our Hispanic Latino youth to European American, but in that 2003 paper, we had a list of the proportion of Hispanic Latino participants. And if you look at just look at the top now, 2003, you see the proportion of Hispanic Latinos, and you can see none, 2%, 5.4%, none. And then you do see a 37% and a 46%. Those actually are two Silverman trials, because I was, as Andy mentioned, I was at FIU in Miami for 22 years before I moved to Yale. So these were trials that are using Miami samples. So that's what it was in 2003. In 2021, a recent paper came out that you can see the title there by Paris and colleagues. And this is a direct quote. In 2021, now they're just looking at CBT and parent studies. 3 out of 11 studies did not report ethno-racial composition. I'm not even talking about Hispanic, Latino, just like nothing. And 1 study did not report specific ethno-racial breakdown. And most studies reported less than 10% ethno-racial minority groups, with the exception of 1 study. And here they now cite, because this was a review of CBT and parents, and they cite our 2009 CBT plus parent studies, where we had 61%. So this is a point to say that we needed to really improve our samples. In Miami, we were able to do really great, but even outside of Miami, it's really important, and this is not okay. And I hope when I have to do another slide like this 10 years from now or 15 years from now, it will look better than it does in 2003 and 2021. Okay. Now we get into the stuff that now we get to really, for me, super exciting. So now I'm going to speak about what we've been spending some time on, which is parents and the role of parents. And remember, I told you that Kendall's first trial was in 1994. Our first group cognitive behavior therapy trial was in 1999. I don't know if you guys were alive then or not, okay, but that's when it was. The first CBT plus parents study was in 1996. That was Paula Barrett and Mon Rapay and the Australian group, and that was in 1996. Okay, that was the first time there was a trial. And And so there wasn't that much. In 1994, Bill Catine is a colleague and friend of mine, a close collaborator of mine. We wrote this book for clinicians called Anxiety and Phobic Disorders. And so we were making this up because there wasn't anything out there yet. You know, when we wrote this book, mainly for clinicians in 1994, we published this book. And we basically said that there's something called the protection trap. Oh, I'm sorry. There's something called the protection trap, which means that children with anxiety are avoidant. They show distress. Parents protect. They love. They want to not see their child upset. So they do things and to allow their child to avoid. If a child doesn't want to go to school, they're very upset. The child and parent might say, okay, Andy, you could stay home with me today. You're so upset. And this leads to short-term relief to the child and the parents, and the child continues to avoid, and it leads to maintenance. And we called it the protection trap. Of course, we borrowed this from, I said we made it up, but we didn't totally made it up because it was very much based on the coercive cycle of Gerald Patterson, and it's it is a negative reinforcement trap. That's what this is. And we then continued in our book where we then wrote an article there called where we have the theory in child psychosocial, have it or had it, and then we published a trial which essentially was testing this theory, and we called it a transfer of control model. Or now I kind of wish we called it a generalization model, but basically we said, look, we can be pragmatic. We can work with children with anxiety disorders in pragmatic ways. And we could do one thing is we can work just with the child and do cognitive behavior therapy, or mainly cognitive therapy. And in the article that you see that we published, the 99 trial, which I should say is with specific phobias. This is the one study with phobias. We work just with the child. That was one arm of the study. Then we said, another way pragmatically to work with children is, focus with the parents, train the parents. We called it contingency management, but it was very much negative reinforcement. Based on that negative reinforcement, teach parents not to engage in negative reinforcement. Don't allow their parents or let their child to avoid. And then we also talked about a full transfer of control, where you can do both. You can work directly to the child, and at the same time work parents with child. And we tested in this trial that's up there that you see published, contingency management, self-control, and its support. We basically tested the arms. We didn't test the full model. We tested exposure CBT, the one in the middle, and exposure child cognitive. And the findings really, this is really the findings actually, and it's possible that when you see Tom Ollendick, he might have the same slides, because these are actually slides that Tom Ollendick has used with his phobic kids. But basically what I wanted to show is that the children, behaviorally, self-report measures, interview schedules, they showed improvements no matter how we transferred the control. They were both efficacious. So that was interesting to us. The control condition is interesting too, but I'm focusing now on the two transfer control approaches that we've studied. Now, what's even more interesting to me is that was published in 1999, and this is a meta-analysis that was published. I actually don't see it, but I think it's like 2014. And this was a meta-analysis, and they looked at all the studies that compared that had CBT with and CBT without parents, and they classified the studies depending on whether or not there was a contingency management emphasis or a transfer of control emphasis, as I just described. So this is what I'm showing the figures, whether or not they did just through the parents or whether or not they did a full CBT. And the conclusion is that CBT for anxious children is efficacious with or without active parent involvement. But what I find really interesting, because many years later, is that what is sort of the model that Bill Katinas and I had put out is that contingency management or negative reinforcement training and transfer of control, generalizing parents to children, has the strongest evidence for durability. So this is interesting to say there's something going on that may help improve, that may be helpful to do with parents. However, what is the specific, you see I put in red, what is the specific parent mechanisms that ought to be contained in the transfer control model to enhance CBT alone? This is the holy grail, frankly, in CBT plus parent work. And the reason why it's the holy grail, one reason why it's the holy grail, is that because people have been looking for many, many, many different mechanisms, and I put down below, AKA, some people, NIMH calls them targets. Statisticians might call them mediatums. Clinicians like to call them components. I'm going to be calling them mechanisms. And if you look on this slide, I am not making this up. These are actually, if you look across all the studies that have compared CBT with parents, these are the different ways that parent mechanisms have been targeted. They've targeted acceptance, they've accommodated accommodation, they've done psychoed, I mean, parent anxiety. It's a real laundry list. So on one hand, you could say, well, it's not so surprising that in trying to understand the role of parents in child CBT, trying to understand the role of parents and how parents might enhance outcome, it's been challenging because on one hand, people have so many different mechanisms and different mediators or targets. So, there hasn't really been one thing that's been studied so carefully. It's kind of all over the place. However, I also don't want to quote blame the research. I also want to say for any of you out there who have started working with parents and parents of children with anxiety, it is very hard to change parent behavior, especially in these short 12 to 14 sessions, especially in the very complex dynamic of an anxious child and all that involves. So it's the research, but it's also a real clinical conundrum to figure out what to do with parents and how to make that durable. Let me give an analogy to make this more concrete. When we have a hot fudge sundae, we want to make a hot fudge sundae. We know that we need ice cream, and we know the main mechanism or mediator to make it a hot fudge sundae, we know is the hot fudge. We need that hot fudge. And then we probably need to add the whipped cream maybe, or the cherry, but we need those mechanisms to make, or components to make a hot fudge sundae. When we're doing CBT with parents, we have not really yet identified, we have the CBT, which is the ice cream, but we haven't identified what the hot fudge is. We don't, and sometimes if we just make a cherry on there, that's not going to be a hot fudge sundae. So if you go back to there, some of these things could just be the cherry, not the hot fudge. Some of these things could even, like a pickle could even really hurt the hot fudge sundae. Now, I'm not saying any of those things could hurt, but it certainly may not help at all. So I just want to show you the complexity of trying to identify what it is, what is the component, if we really want to truly enhance CBT, because CBT is helpful, but 60%, no, but as I said, 60% improve, but you got about 40% that don't. How do we involve parents? Parents must be playing some role here, and how do we figure that out? Now, when I did my job talk in Yale, I came to Yale in 2013, but I gave my job talk at Yale in December 2011. And this is actually a slide from my Yale presentation. This is not the title, but the best of it is from my Yale presentation. There is no supportive evidence of enhanced effects, okay? That's what I said, no one of CBT plus parents. And studies measure anxiety outcomes only. It's, even though people want to understand the role of parents, in 2011, 10 years ago, I said it is rare to include parent measures, even to include them, even though we want to try to understand their role in the role of parents. This is 2011. And you guys are way too young to know who 10 Years After is, but 10 Years After is a rock band from a long time ago. And this is an album cover called Deja Vu from Crosby, Stills, Nash and Young. I know you don't know this, but when I was looking at this article that was published in 2021, I said, man, 10 years after, this is deja vu all over again. So I just had to put that record albums to remind myself, because this is the conclusion from this meta-analysis, and you can see the figures on the right. The first bar, graph, standard difference in means and 95%. That's just showing that CBT and parents did not confer advantage over individual CBT. Okay, that was in 2021. CBT plus parents did not confer advantage over individual CBT. Only 6 of 11 trials, and these are the ones at the bottom, 1, 2, 3, 4, 5, 6. You see the 6 trials there. Those are the studies including the Silverman 2009. Only 6 of 11 included a parent-family measure at pre and post. And when they measured, no significant differences were found between CBT versus CBT plus parents. And only Silverman, our study, examined whether changes in parent measures are even associated with outcome or whether or not they mediate. Okay? So the question is, what is it that parents might need to do in their work with their children to improve outcomes? It's a real enigma, because as this slide shows, most studies, even in 2021, didn't even include measures. Okay, I'm emphasizing this because, this is like over, you like to think things are improving, but 2011, it was the same situation. So I'm going to now tell you about what I think based on 3 trials that I'm going to go over really quickly. I'm going to give you the bottom line. I wish cartoons could be our science, because these cartoons are essentially telling you the results of several, many years of conducting 3 clinical trials. The first one, and I love that one, they act like they own me. This is an example, as you will see, of what we call psychological control. And I'll tell you that. The one at the bottom, this is great. I'll have to wake up crying in the middle of the night more often. So this is what we talked about with negative reinforcement and the protection trap. That's what this is. Okay, so I'm going to show you 3 trials now. I wish I had, if I had more time, I would, but I have to just give you the bottom line. We had 3 trials, trials 1, trials 2, trials 3. And I'm showing you here, each trial built on the other one, where this is the transfer of control that we tested here. We always had a transfer of control where we had parents with children. We worked with parents, and we had parents do things with their child, but we also did therapists to the child. That is in that CBT, okay? So it's a full transfer of control. The Manassas and that Manassas review that said, this seems to be where to put some money on, plus the negative reinforcement, as you'll see. So what I'm showing you here are the mechanisms that we studied in these trials. And when it has an asterisk, this is showing you that this is where we found across 3 trials, consistent, robust evidence that training parents to reduce psychological control, which you'll know in a minute what I mean by that, and reducing negative reinforcement seems to be where the mechanism that I think, after my many decades now, not many decades, but many decades, I'm putting my money on these. So let me, psych control, negative reinforcement. Let me just clinically explain what that means, psych control. So we work with the parents and the children, and we have the parents, ways I get too much involved with my child, and then ways to let my child to do it on their own. So like, for example, remind my child what to do all the time, don't remind my child to brush their teeth, tell my child what to wear, let my child make their own decisions. That's what we refer to as some control, or more specifically psych control, like when my child shows fear, stop acting like a baby. Tell my child, Andy, I'm confident. Andy, I know you can do this. So that's psych control. We try to reduce psych control in a systematic manner in these trials. have negative reinforcement, how my child tries to stay away. Child, here's an example, child, it is the cartoon. The child tries to go to parents' room at night. Instead of letting the little girl sleep in the bed, don't allow the child to sleep with the parents, walk the child back to bed. And you can see the other examples of how we reduce negative reinforcement. Okay, so we had 3 dismantling trials where we, these were and they all had this in common. Let me just go to the 3rd bullet. And I do need to make it clear that when I say parents, yes, I do mean mothers. Yes, we do need to include fathers. Yes, it's a problem that we don't have more fathers, but I'm also, you know, we got to begin somewhere, and I'm trying to get samples that are not going to, well, we can, you know, it's important not to get selection factors in these trials. And so that's the reason why we mainly are working with the mothers, because of the selection biases, unfortunately, when you include the fathers. So unfortunate. So the first trial, we compared CBT in parents, and in that trial, we compared it with CBT alone. In the second trial, we did CBT plus parents, and we compared it with group cognitive behavior therapy. There were no parents at all. And in the third trial, we did a deeper dismantling of CBT and parents versus CBT. I know this is a lot right here, but I'm going to break it down really easily for you. So, but the point is 3 different trials with 3 different CBT, 3 different comparators to the CBT plus parent arms. And we measured hypothesized parent mechanisms in all the arms, but we only target those parent mechanisms in CBT plus parents. And again, measuring, as I said, is rare in these studies, let alone looking to see if they mediate. The data analysis are complicated. I'm not going to have time to do this, to get into this. And this is an example from one of our recent publications of the SEM modeling. The slide explains the complications involved. Clearly, you know, you could see here for yourself why it's so complicated. So for the ease of presentation, my results and conclusions are presented with simple means. And I do want to give a shout out though to Carla and Jasmine, who were graduate students and are now project managers of all of our clinical trials. Carla is at Yale with me, and Jasmine is at FIU, and Jim Jaggard is a brilliant a brilliant methodologist and psychologist. Okay, these are the first 2 trials where we did CBT plus parents versus CBT. These are the mediators, the mechanisms in the middle. In the blue, it shows that those were significant mediators, okay? And that's what we, you know, and I told you the group cognitive behavior therapy, don't pay attention to that at the bottom, because that's a whole nother talk about what we found with group cognitive behavior therapy. But we did find an interesting mechanism there, but that's not the point. So, but that's the comparison. But the point is that CBT plus parents in the group CBT site control turned out to be a mechanism, as well as in the first trial. And you can see our sample sizes are quite impressive. And the next trial, the sample size is even more impressive. So doing these studies do involve large samples, and these were single site studies. So that makes it even, you know, we worked really hard to get these samples. And this is an example though of the findings though. We found that in both the top half of the slide and the second half of the slide, what we found though was just like what everybody else found. And that anxiety improved in both arms. Okay, anxiety improved. Whether we worked with CBT versus CBT plus parents, anxiety improved. And when we did group CBT and CBT plus anxiety improved. That's like everybody else. But we did find those interesting mediators. So this is the clinical discovery, except for bullet 1. Anxiety is significantly reduced in CBT and in CBT plus parents. No significant differences. Anxiety is significantly reduced in GCPT and in CBT and found no significant differences. But that second bullet, this is the first time that that comparison has ever been made. So that's an important finding. In both trials, changes in parent site control were associated with changes in pediatric anxiety. This may be a key mechanism. In this third trial, that is, we then did a deeper dismantling, CBT plus parent reinforcement versus CBT plus parent relationship. And in red is what we found mediated. If we decreased negative reinforcement, taught parents to decrease negative reinforcement, it was associated with a change in child anxiety outcome. In the other arm, where we focused on CBT and parent relationship, and those we focused on acceptance and site control, when we decreased site control, it was associated with a change in child anxiety outcome. And look at, and the sample size is, really impressive for a single site study. This paper is actually just got published in Clinical Psych Science, as well. The other one was published also in Clinical Psych Science, and the other one was published in JCCP. And this is the smiley face, because this is, as far as I know, the first time anyone has been able to show that child and parent ratings and child anxiety showed significant improvements in these two different parent arms. So if you look at that, and the child ratings, parent ratings, that the CBT plus parent reinforcement and the CBT plus child relationship skills, anxiety was significantly improved more than an individual CBT. And also, we also saw that when we targeted it, it improved. This is negative reinforcement and site control. It's at the CDQ, the slide. The CDQ is the negative reinforcement scale, the site control, and we showed that that improved. And we trained the parents to do what we wanted them to do, and it improved, but not in individual CBT. Again, no one has ever measures this, but we found that specificity, which is very, very hard to find. Clinical discovery. 2 carefully operationalized and concrete CBTs and parents significantly reduced pediatric anxiety more than CBT alone, including through the 12-month follow-up. CBT plus parents improved site control and negative reinforcement. It did not. Site control and negative reinforcement did not change in CBT, including through 12-month follow-up. Reducing parent site control was associated with youth anxiety reduction. We showed that now in 3 trials. And reducing parent use of negative reinforcement is associated with youth anxiety reduction. This is consistent with Bill Continus and my protection trap that we wrote about more than a long time ago, and contingency management. And the negative reinforcement is that, and in that Silverman et al. 99, and in that meta-analysis that I showed you. So the clinical implication is consider reducing parent site control and use of negative reinforcement to improve CBT outcome. Now, this took several decades, what I just showed you, because those were 3 very labor, high subject burden, intensive work. But, I couldn't be more pleased, because finally, I think I'm onto something, we're onto something. And I want to now that I feel pretty good about these findings, I'm working now with a startup company, and we're going to try to develop with the smartphone. We're going to try to develop concrete, specific, intense digital intervention to reduce parent use of site control and negative reinforcement. Because again, changing parent behavior in 12 sessions is really hard. We had too many other things going on. And I believe if we can be more focused and streamlined, we might get more better preliminary effects. So that's what we're currently working on to move this forward. And I hope, and I hope that this is I'm hoping that this can really lead to something more than just what we're currently getting with CBT. And I also do need to give a shout out to my colleague and collaborator at Yale, Ellie Leibowitz, because some of you may be familiar with his SPACE program. SPACE, which stands for Supportive Parenting of Anxious Childhood Emotions. And we published a trial a couple of years ago in the Orange Journal, where we did where we showed similar equivalence of CBT versus SPACE. SPACE is working only with parents. It's working to reduce parent accommodation. That is, but it's very much parent accommodation. A lot of that is indeed reducing parent use of negative reinforcement. Not, and it's, you know, more than that, but a good part of it is indeed reducing parent use of negative reinforcement. Once we, and now that was what we, and now what we currently have, we now have another grant where we're studying CBT versus space, and we're doing brain imaging of the child. And if we find replication, that space is as efficacious as CBT, then the next step will be to do an augmentation trial, a dismantling trial. So this is another great potential, because this is transfer of control, therapist to parent. Okay, now I want to just really briefly tell you about attention training, because that's what we're spending a lot of time on now, and I think it's really exciting. This will be, you know, since I haven't been working, I've been working in this area maybe for the last decade, as opposed to the parent work, which has been, you know, since the 90s. So, but I'm excited about what we're doing here. So many of you, I think, know what attention retraining is. It's the idea that anxious individuals show rapid bias in deploying attention to threat. So we train the brain to look away from threat to reduce attention bias. That's why it's called attention bias modification training. There, and I highly recommend this biological psychiatry paper, which I believe is in the Dropbox, which show meta-analyses generally show medium effect sizes. So to be more, and we currently, we've had now 3 NIMH trials, and we now have a large R01 multi-site trial doing attention retraining. And Jeremy Pettit is my co-PI in the FIU side with Yale, and Danny Pine and Yair are leaders in this field, and they also are collaborators and consultants on this grant. But for those of you who don't know it, here's a child looking at the computer. The child sees these pictures. Children with anxiety tend to look at the face with the threat. What we do is we tell the child, we put that probe, that little, you know, looks like a less than sign. The child always gets that probe toward at the neutral face, and they're told to press the mouse wherever they see that probe, but they don't know that that probe is 100% of the time looking at the neutral face. In the attention control, it's random. So that's why it's the idea is training the brain, because they are implicitly being asked to only look at the face that doesn't have the threat, the neutral face. It's 8 sessions over 4 weeks, 20 minutes, short and sweet. Hard to believe that it can work, but I've been doing this now for a while, and it is amazing how the parents, I shouldn't say amazing, but it is kind of amazing. The parents are like, you know, many parents are super excited about how they're seeing changes, and the children are reporting changes as well. And we actually, before I show you some of that, let me just quickly show you a step care and cost effectiveness study that we did. And in the step, and what we did with the step care was we had 4 weeks, twice a week. And as I said, 4 weeks, twice a week, that got attention retraining. And after 4 weeks, we gave them 4 weeks of attention retraining. I'm calling it attention retraining, and you'll see why. But basically what I said, you know, that attention task versus the control. 4 weeks, twice a week, 124 people. We asked them at the end, do you want to continue or not continue? 60% said they want to discontinue. 79, and then we assessed those people. And we found that of that 60%, 79% were much improved or very much improved. Okay, after that. Then, and this, I should say this is an open trial. Step 2, we then gave them 12 to 14 weeks of CBT. And after that, 91% were much improved. So this is, you know, this is good. I mean, you can't beat that. That's really good. And the cost, we worked with an economic health economist, almost 50% reduction in time. If you look at that, 6.7 hours in attention retraining versus if they had done a full CBT, it would have been 13 hours. Plus, if they had done a full CBT instead of the step care, it would have cost almost $800. Here, with the step care, it was $433. So evidence for step care working and if it being effective and for being cost effective. Then another thing that we showed in the Orange Journal, and this was actually really interesting, is because I told you how 60%, 60% of kids with CBT will improve, but about 40% will not. And we wrote a grant to NIMH, an R34, and we said, you know, about 40% of kids in our CBT, it will not improve. We think we have a really promising new approach called attention bias modification training. Will you please give us some funds to work with the kids who don't improve with CBT, CBT resistant, and can we please try to see if we can help these kids with attention retraining? We got the money. Luckily, we didn't have such a big sample because, you know, these were kids who were in our trial. So these were like, so, we wouldn't want a lot of kids because that means we didn't have a very successful trial. And these were the, the CBT from the trials I just showed you. But what we found here is that with the CBT resistant kids, the kids who did not do well with CBT, and this is after follow-up, this is kids who had CBT at follow-up, they had anxiety disorders. What we found is that when we gave them the attention bias modification training, we showed improvement on the child ratings of the scale, the parent ratings, the pause, and we also found attention bias and another measure. So that was good. The third bullet, though, is interesting. No significant differences between the attention bias or the control, where they get the, where they get the, they don't get the whole, where they're getting randomly, I'm sorry, not random, where they're getting, where they're getting randomly the tasks, the attention task. And so that's not what we expected. I refer you to that study at the bottom, which is in your, where we look more carefully at what might be mechanisms of that, what drives symptom reduction in attention bias modification trial, a randomized control experiment. That was with the, where we proposed some mechanisms. But here's the bottom. So the mechanism is unclear. So here's the discovery of attention training. Attention retraining is efficient, it's cost effective in a step care approach. If you do attention retraining first and CBT augment second, that's what we did. And that's important for dissemination. Then I also showed you that attention retraining may be a viable augment for CBT resistant pediatric. But what we do not know and what awaits discovery is the mechanism. Children in both attention retraining and attention control show significant reductions. So we do not know the mechanism. So, it's sort of like what I showed you with CBT plus parents, where we didn't know what the mechanism, what's the mechanism. And after like a couple of, decades, I'm beginning to think, well, I think the mechanism is parent negative reinforcement and site control. We do not yet know the mechanism of this, but this is also a much newer treatment compared to CBT. So that's why we now are doing a 2-site R01 trial, Yale FIU. It's only with adolescents with social anxiety, because I told you at the very beginning, those are a really tough cookie to crack, so to speak, to really get them to respond well. So we're doing only this trial with this group. We have a different alternative comparator, since the other ones, we're showing the same. And because of, I told you the sample problems at the beginning of my talk, we know with Miami, we'll be able to get a larger diverse sample. We're also collecting speech task and EEG and eye tracking, just what I showed you at the beginning. All of our studies are doing all of these different behavioral measures. And what's kind of cool is that we also, right before COVID, got a supplement where we're also looking at healthy controls who will just participate in assessments but will not receive treatments, just so we can discover the natural course of attention, because we don't even know what attention even looks like, with or without any treatment in this in this population. So so that would be a really, really important supplemental data to receive. Okay, so my takeaways. I know it was a lot, but I hope it was, but I hope these are my takeaways from all of that information. But is that one, anxiety assessment methods are good to excellent. Okay, so when people are telling you that they're not, I, you can look at those articles and they're good to excellent. We don't need to be ashamed of these methods. Samples are inadequately diverse. Yes, we should be ashamed of that, and we need to do better. CBT has efficacy and effectiveness, and we should be really happy that we can help so many kids who suffer from such a severe problem, but we need improvement because about 40% are not doing well. It makes so much sense, children in a family context, that for certain children, parent involvement must make a difference, but we don't know what it is. But I showed you that through these 3 trials that I'm beginning to think that we can enhance outcomes by reducing parent side control and negative reinforcement. Whether or not we'll get better and stronger effects with that digital intervention, I'm keeping my fingers crossed, and then I'll be very happy, frankly, with what I've done over all these years. And then CBT outcome and enhancement is viable via attention retraining. I showed you that. And we need to understand the mechanisms of attention retraining. Those are the takeaways. And we're currently also now, I don't have time. I could have talked with you about moderators. I didn't have time. I could have talked with you about the rates of change. I didn't have time. We have published papers on these. I could have told you about the group cognitive behavioral findings. I didn't have time. I could have told you about a paper that's now under review where we do attention retraining with subthresholds. I didn't have time. I could have told you more about the behavioral and biological neural targets. Unfortunately, I didn't have time. That's what I could have done. Currently, what we're doing is the attention retraining 2-site study. We're doing that SPACE versus CBT trial. We're also doing failure to launch, where we're basically working with young adults and working with their parents, and we're doing that. And we're also, the future work that we're beginning is the digital intervention work that I told you about. So let me end now with my acknowledgements, and you could see here the Yale team, that I just couldn't do anything without all of these people in terms of Ellie Leibowitz, the developer of SPACE, Colin Marin, who came with Yale with me from FIU, and other postdocs and inside Yale, wonderful colleagues. Marissa there is a PGA who has an asterisk because she helped me so much with my slides. And then you could see my other collaborators. I do want to just end though on a sharing, because I mentioned Bill Katinas quite a bit, because he was my very dear friend and collaborator for my 22 years at FIU. And he unfortunately passed away in November 2020. And Bethany Reed Sutherland was a co-investigator on our 2-site study. She was a young, Bill Katinas was a young grandfather, and Bethany was a young mother. They both passed away during October and November 2020. And I owe a lot to them, and of course, especially to Bill, because I learned so much from him. And I would just say, any of you who know Wicked, because I knew you, I've been changed for good. But I also know that Bill and Bethany wouldn't want me to end like that. I know they would want me to end by saying, Wendy, look at the flowers, look at the beautiful spring, look how gorgeous it is. And you're so lucky you have babies are being born. I recently had a second grandchild just born 4 months ago. And I know many friends who recently adopted babies, dogs and puppies. So I know all of us have had a really, really, really tough year. All of us probably have lost dear friends and family, but our work goes on, our life goes on. And I just want to, say that. And I want to thank all of you very much for listening today. Thank you. And thank you, Andy, for inviting me again.